ICU, of course, we have a bane of using CPAP or high flow without a blender. So giving 100% oxygen is very, very bad in these babies for the long run. There is a high rate of ROP, and you know that the NNF guidelines covers less than 34 weeks, less than 2 kilo babies, while in the developed world it is less than 32 weeks and less than 1,500 gram. And to do ROP screening for such a big population of babies, so the babies above 1.5 kilo and less than 2 kilo is a huge number in a baby in an area with low birth weight babies. So we have created this problem, and now we will suffer because we have medical legal implications of not doing ROP screening. How will the ophthalmologist screen so many babies? So that's a problem we have created. Very important to educate your team. If your management doesn't give you the blender, show them the risk of medical legal liability. There's huge cases where payouts are very high for ROP, and you can convince them by showing them the risk of not doing it. So always use a blender in the labor room. Always use a blender if you're using non-invasive ventilation. If you don't have it, refer the baby out. Don't risk the baby's future because you want to give CPAP without controlling their FiO2. Of course, excessive use of investigations in the NICU comes from lack of confidence, or you may have guidelines which make you do daily tests for a few days or weekly tests and so on. So try to individualize. Same with ventilated babies. Try to wean them quickly to non-invasive modes. Avoid blood gases on a timed basis. Just do it when it is clinically indicated, and the whole team can do the same. And CRP is controversial. Of course, it has a role in ruling out infections, or in a case where you have a strong suspicion to decide on duration of antibiotics. But once the CRP starts trending down, if the culture is negative and baby is well, you don't need to necessarily hold on to a long course of antibiotics, especially if there was meconium stain liquor where the lung inflammation itself could cause a rise in CRP. So we need to be judgmental in using investigations. If you use procalcitonin in the first 3 days, the levels are very high. And it's not due to sepsis, it's because of the metabolism of the procalcitonin or the way it is handled in the body. So obviously don't use procalcitonin in the first 3 days. Avoid excessive reliance on CRP, and tracking it will help you, but to some extent. Don't over-treat because you have a slightly high CRP. Many babies have a CRP of 20 to 30 due after a normal delivery, or a mild like aspiration may provoke it. If they are clinically well, culture is negative, you stop after 48 hours and discharge.